Hello and welcome to Everyone Dies. Relax and settle in for our podcast about serious illness, dying, death, and bereavement. Because even though everyone dies, no one must face it unprepared. This week we continue our series about health disparities by exploring the high pregnancy-related death rate among Native American and Alaska Native women. Today we're going to talk about why this is happening, what the data actually tells us, and what actually gets missed in the conversation about pregnancy and childbirth. I'm Marianne Matzo, a nurse practitioner, and I use my experience from working as a nurse for 47 years to help answer your questions about what happens at the end of life.
And I'm Charlie Navarrete, an actor in New York City, and here to offer an every-person viewpoint to our podcast. We're both here because we believe that the more you know, the better prepared you are to make difficult decisions. And please remember that this podcast does not provide medical or legal advice. Please listen to the complete disclosure at the end of the recording.
In the first half, Charlie's going to talk about midwives and has our recipe of the week. In the second and third half, I'm going to talk with Dr. Gina Ford, a clinical nurse specialist at the University of New Mexico Hospital, about the deaths of Native American women following birth.
In the first half, our recipe this week is double cornbread muffins, brought to us by First Nations, whose mission is to uplift and sustain the lifeways and economies of Native communities through advocacy, financial support, and knowledge sharing. To study Indigenous midwifery, Dr. Gonzalez traveled from Guatemala to Canada. There she met midwives working out of an Aboriginal birth center, which used traditional practices and herbs to support wellness during pregnancy. These midwives created Indigenous pregnancy toolkits and were active in legislation. An aspect of advocacy is helping Indigenous communities maintain their cultural traditions. For example, Indigenous midwives combine modern, professional maternity care with ancestral Indigenous knowledge about pregnancy and childbirth. Gonzalez pointed to forced boarding school education and the indoctrination of religious belief in severing many tribal communities from traditional practices. This severance from traditional pregnancy and birth knowledge wasn't organic. It was intentional, she said. Native American women who were sent to the schools lost that knowledge and didn't hear the stories told in their communities in wintertime. Some traditional birthways were still common by the mid-20th century, such as the Navajo red rope birth or no-sleep songs sung during labor. However, the American Board of Obstetrics and Gynecology intensified pressure against midwifery, and soon many states declared it illegal. One 1942 law outlawed traditional Native American birth practices and required Indigenous women living on reservations to travel to hospitals for delivery. Even in more recent times, Gonzalez said, women were told they could only be safe in the hospital. There's a feeling of pressure to birth there and not outside of that space. Her experiences were transformative. It was pretty amazing to be in a room with over 30 Indigenous or Aboriginal midwives, she said. I said, wait, we can support women to have home births, but this knowledge isn't shared openly, and people don't know it's possible. Today, as the services of certified nurse midwives have climbed in popularity, many U.S. health activists are including them in bills intended to improve the maternal care crisis among women of color. Earlier this year, the Black Maternal Health Caucus reintroduced the Momnibus Act, which focuses on increasing access to perennial care, diversifying the healthcare workforce, and other goals. That includes increasing the number of certified midwives who are practitioners of color. Please go to our webpage for this week's recipe for double cornbread muffins and additional resources for this program. This is the part where we ask for your financial support. Your tax-deductible gift will go directly to supporting our nonprofit journalism so that we can remain accessible to everyone. You can donate at www.everyonedies.org. That's every, the number one, dies.org, or at our site on Patreon under Everyone Dies. Marianne?
Hello, and welcome to our second and third halves of Everyone Dies. We're pleased to welcome Dr. Gina Ford, who's a clinical nurse specialist and clinical director at the University of New Mexico Hospital's Outpatient Palliative Care Program. And she is an ongoing guest here at Everyone Dies as our expert in health disparities and care of Indigenous populations. So welcome, Gina, and thank you so much for being with us today.
Oh, thank you for having me. I really enjoy coming and visiting with you and sharing our mutual beliefs.
So we're going to talk today about health disparities with Native American populations, and in particular, those who have had babies. And I don't know if you know or not, or remember, I'm a gerontologist, and even though I've had 2 babies, I really don't know much about birth and babies. And hopefully Gina is going to be able to help us understand these issues of why large numbers of Native American Indigenous women die from childbirth. So in 2024, which is the most recent year for which data for the population is available, Native Americans and Alaska Native people had the highest pregnancy-related mortality ratio among major demographic groups, according to the Centers for Disease Control and Prevention. So let's just, take a look at those numbers. And Gina, do you have any thoughts that you want to talk with people about as people can see? Well, highest group for deaths.
One of these topics that once you see the data, it really changes how you think about this and how you approach it. And whether you're into gerontology, internal medicine, whatever your scope is, it doesn't matter what field you're in. When you see this, it is really, I think, startling for all of us. I read the article you sent me and reflected on the data, and it's just one of these things, once you see it, you can't unsee it at all. Right. And it does make you just stop and wonder, what is happening? I mean, it's 2026. I mean, we should not be having these issues.
Right. And even with saying that, we shouldn't have 13.6 of non-Hispanic white women dying from having babies in the United States. So there's that too, right?
Absolutely. And, I think diving into this, with the Indigenous women having the highest rates of dying from pregnancy-related causes in the United States. But what's really striking is, and we'll dive more into this, is that most of these deaths are preventable. And I think that's what really, when you start kind of going into the weeds of everything, especially, in fact, for Native women, that number is estimated to be over 90%. It's preventable. Yeah. So we're not talking about really rare complications here. We're talking about missed opportunities. And that's really the other piece that stood out to me when these deaths are happening.
So in response to this disparity, Native organizations and the Center for Disease Control, otherwise known as the CDC, and some states are working to boost tribal participation in state maternal mortality review committees to better track and address pregnancy-related deaths in their communities. Native organizations are now considering ways tribes could create their own communities. So state maternal mortality review committees investigate deaths that occur during pregnancy or within a year after pregnancy. They analyze the data and they issue policy recommendations to lower death rates. So according to the 2021 CDC data compiled from 46 maternal mortality review committees, 87% of pregnancy-related deaths in the U.S. were considered preventable. So that's 87% of all women having babies. Committees reported that 93% of pregnancy-related deaths among Native American and Alaska Native people were considered preventable. 93%, Gina. So, 5 of the most frequent contributing factors among preventable pregnancy-related deaths in 2021 were, let me pull this up for you. So the 5 most frequent related factors: substance use, lack of continuity of care, lack of access and financial resources, failure to screen or inadequate assessment, and clinical skill and quality of care. So can you talk about each of these, Gina?
Yeah. Well, I think that it's really important because when we think about maternal, when we think about these deaths, we tend to think about delivery as the risky moment. But most of these deaths are actually happening after people go home, after the baby is born, weeks to even months later, in some cases even up to, as you mentioned, a year postpartum. So this is really about, in most cases, what happens after birth, when people are recovering, caring for a newborn, and often doing that with very little support. And so when you look at the causes, mental health conditions, substance use, and infections, all of those are, as you mentioned, leading the list. But I do want to pause there for a second, because this is where the conversation can go in the wrong direction. It's very easy to hear or read substance use and kind of shift into blame. Mm-hmm. But that's not what the data is telling us. And I think it's really important that we kind of take a time out here, especially when it comes to health disparities. Substance use in this context is often a marker of something much, much deeper. It is tied to untreated mental health conditions, trauma, lack of access to care, and systems that are not set up to support people early enough. So instead of asking, which I think we've all inherently done at one point or another, well, why is this person using substances? They just had a baby. The better question is, what supports were missing? And that is something that we see all too often in Indian country, is there's just not enough support. Because when substance use becomes fatal in the postpartum period, that is a systems failure, not just an individual one. And for me, that is really kind of the thread through all of this. When we talk about disparities, we're not just talking about biology. We're talking about how are these systems built? Who has access? Who has continuity of care? Who is supported? For many, many Indigenous communities, there are multiple layers to this. And, I think as you look through this, the substance use disorder, alcohol, illicit prescription drugs, the lack of continuity of care, lack of access, financial resources, all of this kind of comes back to the multiple layers of this. There's not, a one size fits all, a Band-Aid that can fit it all. But one of the biggest issues that's kind of uniform across IHS is underfunding. The Indian Health Service is funded at a much lower level per person than any program, including Medicare, Medicaid, the Veterans Health Administration, and even the Bureau of Prisons. And so that shows up in very real ways, such as what we're seeing here. So I think that the data is really kind of screaming, we have a real problem here. And it's not just one answer that can fix it all, but, if we're looking at for kind of like what the common denominator is, a lot of it comes down to lack of funding. If we go back to what we've talked about before, a lot of people live in very remote areas. And so being able to access care is very difficult. So if they rely on IHS as their primary care, they may go there for their prenatal care, but deliver somewhere else. And then, going back home, it could be 4 hours from where they delivered. A lot of, certain places like, IHS may have one or two public health nurses covering several hundred square miles, and they're responsible for large populations across large distances, which means they simply cannot check in, every week. Some of them may see a patient once a month, once every few months, or even less, depending on what's going in. And so while there are structure programs, like maternal or well child visits, and they're developing more, those are very specific touch points. However, in order to get back in, some people travel 2 hours to their local IHS. So they're not designed to catch what happens in between. So if someone develops postpartum depression, early signs of infection, or is using substances to cope, there may not be anyone to see that early. And so this is what underfunding looks like in real life. It's not a lack of effort, but really a lack of capacity. And this is how kind of a system level underfunding becomes patient level risk. And now we're seeing this in real life.
And you're talking about mental health conditions. So mental health conditions and infection are the leading underlying causes of pregnancy-related death among Native American and Alaska Native women in 2021, according to the CDC, in terms of them looking at 46 different states. So this table shows us the causes of death with number one, mental health conditions. So for our listeners, can you tell them how mental health conditions translate into a woman dying after having a child?
Yeah, I think that is really, really important to talk about because, there's a lot going around. I'm sure we've all heard the Tom Cruise and Brooke Shields spat about postpartum depression, but that is a really very real issue. And I think anytime anyone is even prone to depression or anxiety, and then you add all of this on top of it, having a baby, if there's any mental health issues, that is a lot. And then anyone that's ever had a baby, you know what that feeling is like afterwards. And if you're in isolation, it can be very, very scary. And when your body is going through all of those changes, all of the hormones, and you're already prone to that, you may not understand what is happening. And, especially if you're a younger mom, if you're isolated, there's so many levels to that. Does that make sense?
Mm-hmm. So is suicide, is there a high level of suicide in this population?
Yes. Suicide is actually one of the leading causes of death in Native populations. And, with that, I actually can, read you some statistics, because this is something I give quite a bit of talks on, because I think it is really important. I think that this is something that people aren't aware of, the morbidity and mortality as we talk about, but substance abuse, in general is 638% higher than the general population. Suicide is over 90% higher than the general population. And a lot of these deaths occur between the ages of 15 to 50 years. And so we're talking about people that are much, much younger. But most of this is attributed to quality of life, such as disproportionate poverty, discrimination in delivery of healthcare services, cultural differences relating in poorer social conditions. And so, there again is a lot that goes into that. And so when you hear, well, suicide is higher, depression is higher, substance abuse is higher. There's, sociologists that have studied this and studied, for example, there was one group that went to buy alcohol at a local gas station in Albuquerque and had underage minors try and go buy it, and they were denied. And then they went by the reservation, and it was almost 100% of them were able to buy it. And so, there's just lots of factors like that go into that. But if you think about the geographic and access barriers of people living in rural areas and must travel hours to access care, most facilities, don't always have behavioral health services readily available. Public health nurses visiting intermittently, and then there's intergenerational trauma, which, we can talk about. There's financial strains, limited childcare support. Sometimes their partners work very long hours or may be absent. There's a lot that goes into that. And I think I would challenge any of us, would we not feel sad at times if we were going through that?
Yeah. So for our listeners who can't see the table, the list is 40% of the deaths in Native American women following their pregnancy. 40% of the deaths are attributed to mental health conditions, 37% to infection, about 6% to hemorrhage, bleeding, including aneurysms and strokes. 3%, and the rest of these are all 3%. Lung conditions, neurological conditions, injury, high blood pressure disorders of pregnancy, strokes that are not related to those high blood pressure diseases of pregnancy, and heart problems. So those are the primary causes of death in this population. And the CDC found an estimated 68% of pregnancy-related deaths among Native American and Alaska Native American people happened within a week of delivery to a year of their birth. The majority of those happened between 43 days and a year of birth. And that's, if you're seeing such a high population of people dying, you've got the data to say, here's the critical times. Then as public health people that we can say, okay, so we know where we need to target. But the further you are, and any of you who have babies know this, the further you are from giving birth to that baby, the less support you have.
Absolutely. And I think it's important to note here, and I think a lot of people don't realize this, that the care is really fragmented. And I think this kind of adds to the complication of it. Most Indigenous Native women, the births occur outside of IHS facilities. And so people are, may give birth in, just regular, state-owned or, regular hospital. But as we all know, after you have a baby, you don't have usually prolonged hospitalization. You go home. And so people are often moving between different systems that do not communicate well. So they may go back home. And this is where people fall through the cracks. And then there's difficulty with access. Not everyone has consistent coverage with Medicaid or Medicare. And even when they do, it doesn't mean there's providers nearby. For example, we all know I live here in New Mexico. The Navajo Reservation is here. And so, that covers 4 states. It's a huge, huge area. So even for our patients that have that, they have to drive several hours to get to an IHS, hospital. And even then, that doesn't mean that they can deliver their baby there. And even if they have Medicare or Medicaid, again, they may be, transferred to another facility. It doesn't mean their providers there or those providers accept that insurance. So just because you have coverage doesn't mean you actually can access care. But I think something else we need to talk about, there's a trust issue. And I think that this is really important to say out loud because it's not talked about enough. And this is something I've spent time, publishing about, thinking about, speaking about. And it's really hard to overstate how recent and widespread this is. Much like how with our Black Americans, they had the Tuskegee syphilis project, we had forced sterilization, and it was not that long ago. And, there were widespread forced sterilization of Native women throughout IHS in the 60s, well into the 70s. And it was actually funded by the Department of Health, Education, and Welfare, and it subsidized 90% of the costs. And, we really don't know how many were sterilized. It's believed in the thousands, but we do know that the estimation believes is about 50% of Native women of childbearing age were sterilized. We know that the youngest one was 11 years old. This is across multiple states, communities, affecting thousands of women. Sterilizations included tubal ligations, full hysterectomies in the absence of any health issues. And these women were being threatened with claims that their children would be taken away if they didn't comply with sterilization. Other cases of abuse, saying providers telling them, that they would be able to have babies again. This wasn't going to affect them. And this was all the way into Northern Cheyenne community, into Oklahoma. It was actually a physician in Claremore, where I was born, that was the one that sounded the alarm and was like, wait a second, there's been 300 hysterectomies in a 2-month period. And so, the U.S. Government Accountability Office investigated, has documented thousands of these procedures without proper informed consent. There is still litigation, policy change, acknowledgement, but this is not distant history, and so many people remember this. People remember. And so when we think about this, it really does impact how people view their health. And it is very scary to think, okay, do I go in there and do I have a baby here? Do I get my prenatal care here? Are they telling me the truth? Because if you think about it, as we've talked about before, I have many patients where English is their second language. They have their mothers, their grandmothers telling them, well, we'll do prenatal care for you. Don't go there. They're going to take your baby. There's lots of things like that. We've talked about the boarding schools before. That went up well into the 60s, So there's lots of this intergenerational trauma that people remember, and it was not that long ago. And that lived experience directly shapes, the trust in healthcare today and how people view it. So when we talk about mistrust, it's not abstract. It's really grounded in real harm. And when that trust is broken like that, it doesn't just reset overnight. It carries forward across generations. So I think if we take a step back and kind of put it all together and look at the underfunding, the limited workforce, the fragmentation across the different healthcare systems, the access issue, the barriers to that, the trust, it kind of becomes easier to at least get a glimpse, a picture of how preventable deaths still occur. And, as we've talked about from a clinical standpoint, one of the biggest gaps is the postpartum care. We're very, very good at the acute moment. I think that's what hospitals are built for. We're great at that, if something's going wrong, but we're not really good at what comes after, as you mentioned. That's kind of where we all drop the ball. We don't really know what to do. And that's not, big and fancy, and, it's not adrenaline. And so, I don't think there's a lot of money that goes into that. But prevention here really means we have to stay connected. We have to follow up and check in and see how people are doing. It means, really ongoing care, repeated mental health screening, and normalizing these feelings and saying it's okay if you feel that way. It's okay. It doesn't mean anything's wrong with you. And making sure if somebody feels wrong, people can access care quickly. And, I think that that's important because I don't think that it's talked enough about. I don't know about you, but I don't feel like it was with me.
Well, I was fortunate when I had babies that I was teaching, and one of my good friends was the maternal child health teacher, and she was around and available, and because my oldest was breech, it was a planned C-section, so she had clinical on Tuesdays and Thursdays, and she was planning on a Tuesday or Thursday, so that she was there. It was like I had a lot of support from that point of view. But then my family was in Michigan. I was living in New Hampshire. I didn't have family around to help, and there were times it was really, really, really difficult because it was only my husband and I to care for those children who, as I had two that were 13 months apart at age 40. And so, it was hard. And I sometimes think, to this day that I'm tired because it's like post childbirth fatigue that's now going, into my 60s.
No, I agree. I tell everyone I've been tired since 2002. So I'm with you on that. It doesn't go away.
And we have cars that work, and it's certainly, like if we need to go out and have a dinner or go out and do something, that we can afford to do that. And so, but living in a rural community, and if you don't have even a vehicle that works,
or running water, a lot of people
you're stuck.
don't have running water here, and I can't imagine doing, that all over again with no running water. I mean, that's just mind-boggling to me, but it's done.
It is.
Okay. No.
So there was a study published in 2024 by Liddell and his colleagues that analyzed data from 2016 to 2020. And they found that approximately 75% of Native American and Alaska Native pregnant people didn't have access to care through the Indian Health Service around the time of giving birth, meaning that, as you said, they had to go someplace else. More than 90% of Native American women's births occurred outside of IHS facilities, according to the agency. For those who did deliver in IHS facilities, that's Indian Health Services, a 2020 report from the Department of Health and Human Services found that 56% of labor and delivery patients received care that did not follow national clinical guidelines. Now, how does that happen in a healthcare facility that 56% of the people are not getting care, sort of the standard of care, if you will?
So, again, I think that it's going to come down to, kind of the underfunding that you're seeing there. And it really, it comes down to the guideline adherence, the structural inequities, the geographic isolation, underfunding of IHS. And, they're expected to follow the national clinical guidelines. But, there's well-documented challenges that, are it's consistent implementation due to resource limitations, access barriers, system inequities, and I think all of this contributes to the disparities. And it's really, really hard. But I think when people hear that, it kind of goes back into like, should we deliver there? Should we not deliver there? But some of these places are extremely, extremely isolated. And the people that are out there, I think, I guess my thing is it's really hard to translate unless you actually see it. I mean, it really is like going into a different country and seeing how they practice medicine. It's almost like traveling back in time. And so, I think that...
Don't they have the same accreditation standards
the issue is not that the guidelines don't exist. It's the ability to consistently implement them, shaped by resources, geography, and history and what's available to them, oversight. And I think people look at this a different way. I've worked with some of the best providers that, just go above and beyond and are truly dedicated to the mission of IHS and choose to make that their career. And I would let them take care of me and any of my family. And I'm so fortunate to know them, and I call them for help. Then there's others that are looking to, establish here and have to, pay off loans, whatever it is, but they have to go work in a under-resourced area. And so are just kind of buying off their time or paying off their time. And so we'll go work for a couple of years somewhere and say, I'm just here till, I can pay this back or whatever it is. And so they're not really dedicated to, the mission of IHS, it's not really their calling, and they're just doing that until they can go on and to another paying job. And so you can almost tell that the difference in the mentality if people want to be there versus they're just like, I have to be here right now. But I think that a lot of it also comes down to access and care. Some women have to deliver there because, that's where they live. That's what they can afford. It's a geographic necessity, cultural familiarity, financial insurance barriers, and it's what they know, what they're familiar with, and it's what's best for them at that moment. And they may not know, what it's like in other places. They may not have the option, I guess is what I'm trying to say.
Right. This same 2024 study, the authors also found that members of the population were less likely to have stable insurance coverage and more likely to have a lapse in coverage during the period close to birth than non-Hispanic white people. So here they are, in a situation where they're going to give birth and then something happens with their health insurance, which certainly is not contributing to the health of these women and their babies.
Mm-hmm. Mm-hmm. Yeah, absolutely. And, I think that could be a whole nother talk about IHS, access to care. And, if we use that as insurance versus having, Medicaid as backup or insurance through your employer. But once you have access, you access IHS benefits. In theory, you can go to. They'll help you do what we call contract health. So you can go to them and, you're pregnant and say, I'm going to deliver, and they'll help you go to another facility. So, because most, I don't know the statistics off my hand, but a lot of IHS facilities, they don't deliver. And so I'm thinking in Oklahoma, I think there might be 3 out of all of them that actually will deliver children. And so if you're pregnant, you can do your prenatal care there, but they're going to send you someplace else to have the baby. So you'll have your prenatal care at your local IHS, and then you go someplace else to have the baby, and then you may do your postpartum care somewhere else. So again, this fragmented care. So again, it really just kind of depends on where you are, and what your availability is.
And plus that relationship with your doctor, like for me, and I don't know for you, but the same woman did all of my prenatal care and delivered the baby and all my postnatal care for both kids. So there's this years long relationship, so that like if I was getting depressed or I was feeling suicidal or whatever, she knows me and she would say, oh, there is a difference, there's something going on, what are you not telling me? And so that relationship makes a big difference in terms of being able to have your mental health and your physical health needs met.
Absolutely. You need to be able to feel comfortable
Right.
talking to someone and telling them this is how I'm feeling. And if you don't have that relationship, you're not going to be able to bring that forward. And it is really, really challenging. I think people don't always know what's normal, what's not normal, and how hard this can be. And to say, it's okay to feel sad. Sometimes it's okay to feel angry. And this is, what I want you to talk to me about. Like you said, having that relationship with your provider, it's so important, and not everybody has that. And especially if you're fragmented, and in some IHS locations, there's a different provider every time you go in. So you may not even be assigned, and they float between different ones. I remember really distinctly, there was this one in Clinton that my grandmother did not like. And so she's like, I cannot see her. She's like, I don't like her. And she goes, so let's go to Watonga. And that was like an hour and a half away. So I drove her to Watonga, and when we were sitting in the, waiting room, and then the provider walked out, my grandma goes, oh no, it's you. And I was like, oh my gosh. She was like, we drove all this way so I wouldn't have to see you. So, there's no guarantee who you're going to see. You just show up and you're going to see someone. And so you may not, even if you go to IHS for months, you may not see the same person. And so again, fragmented care. I mean, there's just so much around that, which leads to increased anxiety, isolation in an already scary time.
Mm-hmm. And I'm sure it didn't help her relationship with that practitioner to know how disappointed. So people are probably saying, well, so how can we help? What can we do? Well, one thing is to be aware of the positions that people who are running for office hold regarding funding for IHS and policies that will affect Native American and Alaska Native populations. There's a saying in public health that form follows funding. In other words, what we're willing to pay for is what we're going to get. When it comes to Native American and Alaska Native populations, our inadequate funding of public health services is reflected in the data that we're talking about today. And so one way that you can, help with this issue is to, when you're, all of the factors that you're looking at when you're thinking about who you're going to vote for, is you could look to see what are their positions, or if they're being reelected, how have they voted in terms of funding for different populations or funding for IHS. And if that's something that's important to you, then maybe don't vote for them.
Yeah, absolutely. I think that's very important, but I like this graphic you have up here, because at a very basic level, I think we need to learn the warning signs, and we can listen when something doesn't feel right. And we take concern seriously, especially in the postpartum period where so much of that risk exists. And, one thing, when people call me, whether it's, sister, cousin, whomever, and ask me, what do you think? And I'm like, well, it doesn't really matter what I think. If you're worried, you need to go in, because I think we know our bodies, and we need to start listening to ourselves and trusting our instinct. And if we feel like something doesn't feel right, then we need to go get it checked out. It's better to be safe than sorry. But we also need to support people in getting their care. And so that means encouraging them to call their provider and normalizing that, helping them navigate the system, or even going with them to an appointment, because it is really overwhelming. It's scary. So they're not doing it alone. I think all of that's really important. And then from a clinician perspective, not dismissing symptoms, especially mental health or, substance use, these are not side issues. These are central to survival in this period. And at a systems level, this is about, as you talked about, investment, design, means funding the healthcare system that serves our communities at a level that actually matches the needs, and really improving coordination, so people aren't moving between all these disconnected systems. I mean, it's really exhausting for everyone, and it means extending postpartum care beyond just a single visit, making mental health and substance use support a standard part of care without the stigma, attached to it. But most importantly, it means including Native voices in decision-making, because the people most affected need to be part of the solution and what feels right for them. And I think one of the most important shifts is how we think about this, how we talk about it. And instead of asking what individuals should have done differently, we should be asking, where did the system fail to support them?
Right.
Because when we say these deaths are preventable, what we're really saying is, well, there were missed opportunities to listen, opportunities to follow up, opportunities to intervene early. We already know how to do better. Clearly, you can see from the graph. I mean, we're doing better in certain populations. So the question is whether we're willing to build the systems that actually that supports everyone and not just certain people.
That's true. And so this graphic, for our listeners who are listening and not looking, what it is what are the symptoms, or what are the triggers, the things that you might see that could put a woman's health at risk following the birth of her child. So these are what we would call urgent maternal warnings. And all of us, if we've just had a baby or if it's our family or if we're neighbors, is we should know what are things that if you see, you should say, that could put your life at risk. So this list is headache that won't go away or gets worse over time, dizziness or fainting, changes in vision, a fever that's higher than 100.4, extreme swelling of your hands or face, thoughts of harming yourself or your baby, trouble breathing, chest pain or fast beating heart, severe nausea or throwing up, severe belly pain that doesn't go away. If you're pregnant, the baby movement stopping or slowing during pregnancy, severe swelling or redness of arms of your, or severe swelling, redness or pain of your leg or your arms, vaginal bleeding or fluid leaking during pregnancy, heavy vaginal bleeding or discharge after pregnancy, and overwhelming tiredness. And so these are the concerns that as a community, if we have somebody who's pregnant or have just had their baby, these are things that we have to encourage them to go seek medical help. We really need to tell people that if something doesn't feel right, you got to reach out to your provider. And I understand the barriers to doing that, but even if it's going to the emergency room, it's your life. If you're having any of these symptoms that I just talked about, you need to get medical care right away. If it's somebody, that you say passed out at the grocery store or whatever, asking, are they pregnant? Have you had a baby within the last year? Because we know from looking at these graphs, that's a critical period in terms of maternal health. As Gina said, offer to go to visit the healthcare provider. Even to just maybe write down answers or remember to ask the questions of the things that's bothering them. Sometimes people get into that room and everything that they've thought that they want to talk about, they've kind of forgotten. And so having somebody there with them really can make a difference. And also to support them through their follow-up care. Having the baby isn't the end of the story, right? It's just the beginning of, the next forever. So any final thoughts, Gina, that you want to leave with our listeners?
Well, I think I've yapped long enough. But again, I just think if we really believe that these deaths are preventable, then the work is not just awareness. Again, it's just, really building systems that actually make prevention possible for everyone.
Right. Well, Gina, thank you for coming and talking about this topic with us. And it's always great to see you.
Thank you for having me. I appreciate it.
Thank you.
Thank you, Marianne and Gina, for your interview. And with that, we end this week's episode of Everyone Dies. Thank you for listening. You can find more episodes about disparities on Spotify, Apple Podcasts, or your favorite podcast app. Follow and subscribe to the show. Share it with someone who needs a little hope today. This is Charlie Navarrete. And from Actors, or Ian McKellen, the question isn't, are you prepared to die? The question is, who will you be when you die? The question is, who will you be when you close your eyes?
And I'm Marianne Matzo, and we'll see you next week. Remember, every day is a gift.
This podcast does not provide medical advice. All discussion on this podcast, such as treatments, dosages, outcomes, charts, patient profiles, advice, messages, and any other discussion are for informational purposes only and are not a substitute for professional medical advice or treatment. Always seek the advice of your primary care practitioner or other qualified health providers with any questions that you may have regarding your health. Never disregard professional medical advice or delay in seeking it because of something you have heard from this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Everyone Dies does not recommend or endorse any specific tests, practitioners, products, procedures, opinions, or other information that may be mentioned in this podcast. Reliance on any information provided in this podcast by persons appearing on this podcast at the invitation of Everyone Dies or by other members is solely at your own risk.